Good afternoon, everyone. I would like to thank you all for coming today and really giving us an opportunity to speak to you and ask questions. Couple of things. Who is the project manager over JFL North?
Good afternoon, Senator Heiliger. That would be Ms. Yvonne Thomas.
Okay. In discussing some of the things, and we did have an opportunity from my office to attend and view the site, there were several things that were noted, especially when it came to security. For example, what do you have in place or what do you plan to have in place when it comes to the protection of patients' privacy? Because noted in some of the things I was able to witness, basically in the open area, people could listen and hear all of people's information. And that was a major concern for me. How is that going to be mitigated?
And so there's several approaches to protecting patients' privacy when we're dealing with healthcare spaces that are out in the open. We look at the HIPAA standards, which is, of course, federal mandated standards, and it really speaks to how patients can be registered when they come into emergency room. And there are permissions under HIPAA that does allow registrations to occur in an open space. Separate and aside from that, of course, we make every effort to protect patients' privacy when they present to our clinical areas. And we have looked at additional key be comfortable with using some of the technology.
Director
and
Williams,
so we're really looking at best.
Director Williams, go back to comfortable. You paused at that time.
Okay.
Okay. Rephrase the last portion of what you said.
Okay.
That works, Senator?
Sure.
Gallagher?
Huh?
That's fine?
Yeah, she can go
Okay.
ahead and.
Go ahead.
Okay, my computer was doing something crazy on this end. Can everyone hear me?
Yes.
Yes.
And so I was speaking specifically to the HIPAA privacy as it relates to open spaces. There are provisions that do allow for us to take information in an open emergency waiting room because, of course, the federal government understands that every hospital emergency department is built exactly the same. I will share that we have taken additional steps in terms of just understanding that this is a small community and everyone is deserving of their, protecting their privacy. And so we have looked at additional kiosks that persons can enter information themselves, and so that there's less dialogue and more entry by the actual person that's presenting. We do, of course, have to accommodate those patients that may present that may not necessarily be comfortable with the technology, or they may be ADA considerations. So we're overlaying that in any of our considerations as well. And in the individual units, we do have space set aside for private discussions as well, as we are cognizant that this is a small community and people are vested in protecting privacy.
Okay. Second question, in regards to ADA compliancy, one of the things that I noted in looking at some of the photographs that were provided to me, what is happening in regards to the completion of the ramp here? I'm not sure if you know this area, if you can see it. In addition to making sure how the entire JFL Hospital North will be ADA compliant for individuals coming in for services.
We had the opportunity to have Mr. Julian Henley of the Disabilities Rights Advocacy for the Virgin Islands. He's actually participated in assisting us with doing various walkthroughs here on campus. And he's actually been very instrumental in giving us very pertinent feedback so that we are complying with the ADA requirements. There are some opportunities for some additional considerations, but we have been very open and collaborative with those resources in the territory that can assist us in ensuring that JFL North meets the ADA compliance statutes.
Okay. Other question. Dealing with equipment that's necessary. I know you've been able to get some equipment from vendors, et cetera, but tell us a little bit about what's happening with the urinalysis machine, because from what I understand, there's a major situation with that.
And so we're going to have to, from operational funds, purchase our own urinalysis machines. There were some challenges with vendors in our existing JFL that we offered them an opportunity to transition with us to JFL North. All but one respondent showed interest, and some of that, of course, equipment had been previously leased. And so in making the best determinations for JFL North, we'll go ahead and purchase that urinalysis machine for continuation of operations.
What is the cost as opposed to leasing?
1 minute, 30 seconds.
I couldn't speak to the cost of leasing, but the cost of purchase is approximately $50,000 to $60,000.
Okay.
And I would imagine that leasing would be probably more affordable than that. But in terms of purchasing it outright, we're looking at about $60,000 or so.
Okay. One of the things I had read in the testimony. One of the things I had read in the testimony and listened to Mr. Finch, he spoke about the board's role as it relates to the oversight and doing a variety of things. Support, we provide approval for sections of vendors, ensure procurement protocols are followed, etc. When it came to a lot of the changes and modifications necessary, why were some of these things not originally included as opposed? That's why I asked you who the project manager was, because I'm finding from what I'm reading and understanding is that when you put things in it originally and then you have to go back to request additional funding from FEMA, sometimes you're getting a little bit of pushback. So my question is, why were some of these things not originally included, and why are we in the position we're in right now?
And so if I may, Senator Heiliger, the determination to remove like the FF&Es from the original procurement contract were made prior to any of my executive team members or my project managers' engagement with JFL. And so at the point of now coming on and doing our assessments, and the determination was made that the FF&E, which is essentially the nuts and bolts of the entirety of that building, all the medical equipment, the IV pumps, every equipment that goes into the lab and the pharmacy, we actually had to engage up until Congress to really pursue the FF&Es being removed from that original contract. So the FF&E was one significant consideration. But if you can imagine a physical building not being as a hospital that also has to have medical gases piped into the different clinical spaces, because the FF&E was not included in the contract, there was also deficits in the inclusion of other critical considerations in that original contract. And so it's not a matter of us as a team not making the determination or pulling it out and then we're trying to force it back in. When we inherited this project, it was never included. And as we've discussed in this testimony, it takes considerable time to now put it back in because it now needs to go through a federal process that can take anywhere from 90 to 186 days, as we represented in our testimony. And so at the point of discovery, and if we go back to the timeline, you'll see some of those submissions as early as, I think, January of 2020. And following the procurement process and all the federal statutes specific to procurement, it really does take a significant amount of time to work through the entirety of the procurement. And so that's why you're seeing these significant delays at this point.
Okay. Thank you so much for your responses. Appreciate it.
My pleasure. And if I may, Senator Suru?
Yes, you may.
If I may, as a point of clarification, there's something that I want to clarify for the record. I think you had asked specific to the CMU building. Can you hear me?
Yes. I get nervous
Okay, thank
when
you. And so you would ask,
I'm sorry?
No, I just get nervous when you pause for a while, but go ahead. I have PTSD right now.
As do I.
Senator Francis Halliday, you're recognized for your time.
Good afternoon. Point of inquiry to the chair. One of the reasons why I asked the question earlier about project management and all these other things in regards to how things are being done is for this very reason, this part of this discussion we're having now. Through the chair, I would like to request a job matrix from JFL through the interim CEO to get this job matrix as it relates to the various positions, what their titles were, to include contracts that we can see, because I'm a little bit concerned right now as to what I'm hearing. I really am trying to get a grasp of who is really doing what, because as I sit here, I am continuously hearing from multiple people, I was not here. And that almost sounds like an excuse as to why I am not getting the information I need. So if you could give me a job matrix that can assist me in better understanding who was where, who was in what position, so I could know who actually made some of these decisions. Because in order to solve some of the problems, we have to know where the issues occurred so they don't reoccur again. So that is my request. Thank you.
Senator Francis Halliday.
Afternoon. How is everyone doing? Couple of questions I want to ask specifically. I know we were discussing a little bit earlier about the disparity between the 50% threshold for the hospital and this new reassessment that, as in one of the testimonies they did share, it's gone up to like 70% now because it wasn't there before, and there's a little bit of contention. I'm trying to understand what are some of the things that has changed specifically to alter it from not making the threshold to now that it has, based on your assessment, and that's one of the issues back and forth with you and FEMA.
Good afternoon again. Thank you for the question. I will allow Mrs. Smalls to answer, but to the effect of what we talked about with the Bipartisan Budget Act and the 428 rule, the ability to include pre-existing conditions, which was not something that was being done before the BPA, the Bipartisan Act, the ability to include that is what would kick those expenses up, that would allow it to now be considered above a certain amount of repair percentage of the actual total replacement costs. I'll allow Mr. Smalls to add to that if there's anything else for your question.
No, basically, as Dr. Myrah said, that's what it was based on initially. Even with the BBA and the 428, the rules that had to be promulgated once the Congress made that declaration, that didn't come when they passed the act. All of those rules had to be promulgated, and subsequently, that's how we've been able to apply a lot of the pre-existing conditions and certain parameters that were not in the initial assessment.
Okay. The other question I want to ask has to do with Myrah Keating, the Cancer Treatment Center. That was plagued with a lot of issues even before the hurricane and even trying to provide service to the territory. I remember from reading a report, there were initial assessment that the center potentially could not have sustained itself based on the population and how much based on who's getting cancer. My question I want to find out, in the rebuild, has an assessment been done as to what it's going to be utilized for in your approach to get a new design if you're going to be able to rebuild it? Because if we were already having issues prior in providing the services to the community, because some of the issue had to do with financial as well as the population, what is going to be the decision now? Because you ultimately are going to have to design it in a way to serve the public, but what services are you going to offer?
And thank you for that question. And you're specifically talking about CKCI. Yeah. It's been a long-standing issue as far as from a medical standpoint not only with that service, there are a number of other services that have been a financial strain and drain to the organization. Specifically with CKCI, the cancer treatment therapy and the radiation, well, let's just say cancer treatment therapy on the whole has always been, because of the financial structure of the hospital and its inability to recoup above its costs in the TEFRA type reimbursement that we receive, it's always been a bit challenging to maintain this part of the organization financially, because we just don't recoup those costs that we spend in the very expensive chemotherapy drugs. We are unable to apply for a particular financing that allows for higher reimbursement. And so this is where, very importantly, as we spoke of in our budget hearing, the importance of rebasing becomes extremely paramount to our ability to run that program. So yes, we know that it has to come back up because radiation oncology services are paramount to cancer care and to the people of the Virgin Islands. But it is a concern how we are going to be able to maintain that financially until we get rebased and all expenses can be entertained.
And is this part of the current discussion that you're having in regards to potential layout, design? Would you have to build it smaller? I'm trying to get a little bit more in regards to knowing that if it's a financial burden, how do you fix that and still try to accommodate the community at the same time?
So really the design, the structure, and the building itself is not really per se the problem.
Okay.
The problem is the financial structure of our billing abilities from the hospital perspective. We have not been rebased since the inception of TEFRA here in the organization since 1982. And so it does not consider many of the new services, and we have attempted many times, even based on CKCI, to be rebased, and we've been denied by Medicare. It takes a significant, by CMS, it takes a significant change and alteration of services, being able to prove that to them, to be able to get rebased and see the funding commensurate to the cost of our care. I think significant plans are being done by the delegate to see how that can be improved upon.
When you guys make requests from ODR, Office of Disaster Recovery, is it a situation where you are just given what support you requested, or do you guys have some say in what type of help you get?
Senator, could you be a little bit more clear in what you're requesting?
Well, I'm trying to understand across the board with the hospitals. For example, we were speaking earlier about the projects that are coming online and dealing with the consultants, et cetera, with O'Brien, TSG. When it comes to getting specific types of assistance, and from what we're understanding, ODR supplies these type of support. Do you guys have any input outside of just making a request as to what you need, as opposed to them just assigning someone to you who might or may have the qualifications necessary in order to get the job done?
To date, we have not had the need to request any particular services. However, going forward, if the need arises and they had the opportunity, the ability to provide those services, we would consider it, yes.
Time.
Thank you.
You want to follow up?
Well, part of what I'm trying to get to, I'm getting very much concerned about a lot of the discussion we're having around these consultants. And I'm genuinely trying to get to the root as to where these monies are being funneled. And when we speak about some of these projects moving from one cost to another, I also recognize that based on the project, a percentage goes higher to these consultants the bigger the project grows. So for me, I'm kind of trying to understand some of this. You understand what I'm saying? Because the more money you spend on the project, the more money the consultants make. And I'm trying to see what is really genuinely being done to make sure that the people have the necessary buildings and equipment to be serviced them here in the territory, as opposed to things being done for monies to be funneled in various directions, as to say it in a nice way.
I understand your concern, and what you're saying, it is a valid concern. It is really up to us to manage that process and not just arbitrarily take on services that we don't need.